Okay, so thanks very much. As I say, I'm going to talk about, title of my talk is Tumour penetration of therapeutic antibodies, implications for cancer therapy. As I say, there'll be some overlap with some of the things that Dave has talked about. I think that's fine. It's no bad thing to hear things twice. So, kicking off, what I'm going to try and cover, I'm going to talk a bit about, just as a brief introduction. Dave's done a great job in introducing the topic, so I haven't got a lot of slides on these first two bullets of factors influencing tumour localisation and the impact of size, but I'm mainly going to focus on showing you some distribution data, and I've really reviewed the literature. We've also carried out some studies ourselves looking at antibody distribution in tumours, so that's the sort of data I'm going to be showing you. And then I'm going to really hopefully generate a bit of discussion about, is distribution the thing that's limiting anti-tumour activity with antibodies, or are there other more pressing problems to try and address with antibody-based therapeutics? So there are many factors that influence tumour localisation. We've already heard about most of these. The size of the biological molecule can impact localisation, the concentration, which is related to the dose, the exposure time, which is related to the pharmacokinetics, the clearance rate of the biological. Then he's talked about the impact of affinity. I'm not going to say much about that in this presentation, and also the antigen properties, such as the internalization and catabolism that Dave talked about can impact localization. I'll touch a bit on this in one or two of my slides. Two things I want to emphasize. It's been mentioned already that most tumours have this raised interstitial pressure because of poor lymphatics, and the consequence of that is that diffusion rather than convection dominates the distribution. And so that slows up distribution through the tumour mass. So that's a negative factor. But on the positive side, those tumours have permeable vasculature, and that in part can be attributed to the molecule vascular endothelial growth factor, the target for Avastin. So when VEGF was first discovered, it wasn't called VEGF, it was actually called vascular permeability factor. It's a very potent permeability enhancing agent, as potent as histamine. So this permeability enhancing activity leads to this effect that Dave's talked about, this EPR effect, enhanced permeability and retention. And that leads to this non-targeted uptake of macromolecules, including nanoparticle delivery into the tumours, and also can lead to non-specific uptake of antibodies, as Dave's already mentioned. So if you just inject a non-targeted antibody, you'll see some degree of selective uptake in the tumour, and that data has been published by many different people. So it is important, if you're doing experimental studies, to include a control antibody. So this is my simple schematic of Dave's work, and also actually the work that was published on the DARPin molecules that we're going to hear about later. And so I'm not going to cover this, I'm not going to go over this again, but basically Dave's already covered the general message that small is good. If you have high affinity, you get very good uptake. If you move to an antibody molecule, you can also get very good uptake. And it's less dependent on affinity because of this long half-life in the bloodstream. So rather